Right. Good evening and welcome everybody to our Child Health and Wellbeing Network webinar on paediatric asthma for our primary care colleagues. Thank you so much for joining us this evening for our third paediatric asthma webinar for our primary care teams. This session is being recorded. A few points of housekeeping if I may. Please could colleagues stay on mute and turn your camera off throughout the session unless you're actively taking part in discussion. We're a sizable group tonight. If participants could try to not take control of the slides during the session, this would be really appreciated. The speakers will move through the slides as they deliver their presentations. It would be really great help if colleagues could list in the chat their practice and the area in which they work. That would be really helpful for us to get a sense of the reach for this session. Do feel free to use the chat facility throughout and raise your hand to enable us to facilitate the discussion. We will be sharing this, so if I could just politely remind colleagues to consider confidentiality when discussing practical application. Colleagues from the Asthma Leadership Group will be responding to the chat function throughout. And we have included opportunities for interactive discussion throughout the session, and professionals from the team will be able to respond to the questions or comments throughout the course of the session. Any questions that remain unanswered, we will attempt to respond to following the event, and the chat will remain open for 24 hours after this session is concluded. Next slide, please, Claire. If we could do, thank you, fabulous. So by way of introduction then, my name's Louise Dauncey and I'm a Network Delivery Manager for the Child Health and Wellbeing Network. My main role is the responsibility for the delivery of the Children and Young Persons Transformation Programme here in the North East of North Cumbria. I'm here on behalf of the Child Health and Wellbeing Network and also our North East North Cumbria Asthma Leadership Group. Dr Moss, Dr Ramfull, Dr Hegab and Carol Barwick will lead the sessions with presentations and discussion, and everybody will introduce themselves. The list above provides the names of the other current members of the Asthma Leadership Group, and we have a wide range of disciplines, ranging from respiratory nurse specialists to 0 to 19 school nurses and historically pharmacists. Next slide, please. Thank you. Our agenda for the evening is described here. We have 4 sessions to cover the diagnosis in the absence of objective testing, choice of inhaler, overuse of salbutamol, and the final session is about referral pathways and when to refer. We'll try to keep to time this evening in order to allow time for discussion and questions following each slot. Next slide, please. Can I have the next slide, please, Claire? We may have a possible technical glitch.
It has changed over to the vision.
Okay, what we can see on screen is still the agenda. I'll just talk you through the vision and hopefully we can sort that out. So I wanted to spend a few minutes at the beginning of the session to provide some background and context to the work we do in the Child Health and Wellbeing Network, to describe who we are as a network and what we do, and to provide a bit of background around the evolution of the network and also the mandate and system asks, and describe our priorities and describe a little bit about where we are today as a network. So broadly speaking, the network itself provides a platform to enable collaboration and connections of stakeholders across the system to enhance the services and opportunities for children, young people and their families. I wonder if you want to take it down and start again, reshare again, so that we can try and keep the slides in line with what I'm sort of saying.
Sorry, Louise, we can see them. They're moving on for us.
Oh, yeah, apologies. Okay, apologies. So then the next slide then for me is one with a map and a table on. So I won't go into detail because time is short, but this slide just provides a bit of local context about our local population of children and young people and gives an indication of the size of our geography. The map on the right-hand side shows the 4 area integrated care partnerships and also marks out the 13 local education boundary areas that we cover, which you'll be aware includes 13 local authorities, 13 public health authorities, 8 acute trusts, 2 mental health trusts and 3 ambulance services, as well as numerous primary care networks. You'll also appreciate that the education system forms a valuable part of our ICS, and within this we have over 1,400 education and school settings across our huge geography. Our ICB operates across a wide geography and diverse population with wide-ranging socioeconomic challenges. As a professional working in this area, I'm sure you'll be well aware of the socioeconomic challenges locally and the impact of this on health and other outcomes for our young persons population. And you'll also be aware of the Core 20+5 framework and the recognition of asthma as an area of additional clinical vulnerability. Next slide, please. So this should be a slide with a priority wheel on and our vision statement. So this describes the initial stakeholder engagement which historically had been undertaken with over 1,000 points of contact with stakeholders and families across our system. And this engagement has given us our mandate and identified a range of priorities which are described in the wheel that you hopefully can see. I won't go into detail, however, for those colleagues who are living and working in our local geography, none of these areas of priority will be a surprise given our known levels of deprivation and the various challenges we have locally. Within this, we have a growing role in relation to children and young persons transformation agenda in respect of additional needs, vulnerability and childhood illness. The Child Health and Wellbeing Network has a growing role and an overriding vision which holds children and young people at the centre of all we do. And the mission statement here outlines our vision that children should be supported and given opportunities to flourish, and that we can do this by supporting supporting organisations to work together to achieve this. And our role as a network is to share good practice and drive improvement, allowing platforms for collaboration. Our network is growing and has a broad representation from across the system, including the children's workforce, and we currently stand at over 1,900 members. Next slide, please. So the slide that we should see now describes the Child Health and Wellbeing Network. We have a number of strands of work, including Youth Voice, Health Inequalities and Core 20, an ongoing programme of communications, engagement and training opportunities, and delivery of the Children and Young Persons Transformation Programme and the Integration Centre. The Children and Young Persons Transformation Programme has three main aims in relation to the integration of services, improving quality of care outcomes and experience for young people and their families, and the more ready and active involvement of children and young people. Within this, there are 10 key areas of work relating to the NHS long-term plan, and long-term conditions and asthma are identified as one of these priorities. The Integration Centre itself is a pilot project in our North East and North Cumbria with a number of key components, one of which is the rollout of system-wide education-based intervention to improve the community capacity and to support children and young people with asthma in the wider system. The aims and objectives of these programmes align really closely with the vision for Child Health and Wellbeing Network. So the next slide should just be a single slide with a series of links on. Which basically provide a bit of an overview of the work we've done within the work stream. So throughout the Integration Centre, we've resourced an asthma leadership group with a range of fellows, with a workforce to deliver a range of activities across the system. Examples of this include various points of contact with professionals across the system and targeted work into primary care and community pharmacy, as well as education settings, sport clubs, local authorities, and more recently, the housing sector. The slide describes some of the parallel work that's been ongoing in relation to asthma and the various parts of our complex system. Alongside this, we've developed a series of resources which are hosted on the Healthier Together website, and there are links included on the slide. So, next slide, please. And this should be the final slide for me in relation to the Child Health and Wellbeing Network. I would encourage you to look at the Child Health and Wellbeing Network website to find out more about the various projects. And if you're not a member, please do sign up. I'll hand now to Dr. Ramphal to lead the first session, which is about making a diagnosis of asthma in the absence of spirometry or FeNO. Dr. Ramphal is a consultant paediatrician at Queen Elizabeth Hospital and is also a clinical advisor to our network. She has a passion for working collaboratively to support improvements in care and outcomes for children and young people with asthma. So next slide, and over to you, Dr. Ramphal.
Thanks, Louise, for this nice introduction. So as Louise has said, we're going to talk in a few small sessions, and I'm going to talk a little bit about making a diagnosis of asthma in the absence of FeNO and spirometry. Next slide, please. So all of you here will know what asthma is, but just for us as a reminder, as you can see on the left there is a normal airway, and when you do not have asthma, you'd hope that air would go in nicely in and out, but in somebody who has asthma, there's already a little bit of inflammation and some swelling, and sometimes the muscles are tight and therefore the air is not going in and out as nicely. And when they have an acute attack, then that is exacerbated, and sometimes to the extent that this can be blocked because of secretions. Next slide. We have done previous webinars in terms of describing the clinical features of asthma. So if you would like the link to that webinar, Louise will be able to signpost you to that if you request it. But just again, as a reminder of what clinical features support a diagnosis of asthma according to the BTS and SIGN guidelines, it would be recurrent symptoms of cough, wheeze, shortness of breath, especially if corroborated by variable peak flows. Wheeze heard by health professional is quite helpful if you've got that documented. A family history or personal history of atopy would again indicate a high probability of asthma, and certainly response to bronchodilators and or oral or inhaled steroids would again point to a high probability of asthma. And the other thing would be the absence of symptoms or signs that suggest any alternative diagnoses. Next slide, please. So what are we trying to demonstrate when we are doing objective testing? We're trying to demonstrate that airway obstruction that we know happens in asthma. We're trying to demonstrate a degree of reversibility, and we're trying to see whether we can demonstrate and measure any level of inflammation. And generally what FeNO does is it measures that level of inflammation and demonstrates airway eosinophilia. Next slide, please. In terms of the objective measures, you again might all be aware that there are different guidelines for asthma, and in terms of the cutoff for those objective measures, they are slightly different depending on what guideline you're looking at. So for peak flow variability, whilst BTS and SIGN guidance says a variability of 12%, NICE says 20%. And similarly with spirometry, the cutoffs are slightly different. So we're looking at a reduced FEV1 to FVC ratio, which BTS and SIGN and NICE say less than 70%, but GINA guidelines will say less than 90%. What all the guidelines are in agreement with, though, is that an improvement of at least 12% in FEV1 to either a beta-2 agonist or a corticosteroid treatment would be considered positive and would point to a diagnosis of asthma. Similarly with FeNO, there are slightly different cutoffs depending on which guideline you look at. So 25 and above would be what would indicate asthma according to the ERS guidelines, but the BTS and SIGN and NICE guidance say 35 and above, which is often what we tend to go by. Next slide, please. So there are limitations with objective testing, as we've seen. There are differences in the cutoffs. It is difficult to perform in young children. It can be normal in children, especially when they are asymptomatic or if they've had a course of steroids recently. As I've already alluded, the FEV1 to FVC ratio is variable, and it can be as high as 90% in children. So if we use a cutoff of 70%, we probably may be missing cases. We know that these are tests that are very technique dependent, both from a patient perspective and from the operator who's doing it. So it does depend on the skill of the person who's doing it. And what we also know is that FeNO can be raised in other inflammatory conditions, such as allergic rhinitis in particular. We do know that there is a group of children, for example, who, even when we treat them and the asthma becomes well under control, their FeNO, when we measure it, it's difficult to get it down to the normal level. I used to work for a consultant who often used to say to me that he'd like to find a creatinine in asthma. And whilst all these tests are very good in trying to get us to increase our level of certainty in terms of diagnosis, I'm not quite sure we can say that it is quite as good as creatinine is for the renal people. Next slide, please. So what is the pragmatic approach in the absence of a specific test that will tell us that someone has asthma, and also in the difficult situations that often lots of people find themselves where they do not necessarily have easy access to objective testing? The BTS guidelines talks a lot about, and all of the guidelines really talk a lot about the probability of asthma. and basing your diagnosis very much on in terms of the clinical features. So it talks about high probability, intermediate probability, and low probability. In terms of trying to demonstrate what FeNO and spirometry would help us demonstrate, we could use other ways. For example, we could look at the asthma control test scores before and after treatment. An asthma control test score of 19 and above would be looked at as good control. Often what tends to happen in clinical practice is people will give a trial of inhaled corticosteroids for at least 6 weeks and see whether there's been any response. It is helpful if you're able to demonstrate some peak flow variability before that happens. Certainly if there's diurnal variation or there's a drop with exercise. So if we were doing formal exercise challenges, again, the range that is quoted as being positive in terms of diagnosis for asthma is if there's a drop of 10 to 15%. If you've got a 12% increase post short-acting beta-2 agonist or corticosteroid treatment, again, that would be suggestive of asthma. So when we do not have access to these kind of tests, then using peak flow is quite helpful. Reviewing the progress of these children is perhaps the most important thing to do. So sometimes what we will do quite often in secondary care as well will be to start treatment and then review them and see whether that's made a difference. And that essentially often gives you the answer. It is also perhaps worth saying that sometimes it's difficult to get a diagnosis, and people have a few patients, not many, where they have been told that they cannot get the inhalers prescribed, or they do not get the inhalers in school because they haven't got a diagnosis. And therefore, it can put them at increased risk if we are basing our diagnosis purely on the objective testing. So having a pragmatic and practical approach is really what we are trying to advocate through this today. Next slide, please. There is a document on the Beat Asthma website where you can look at how to make a diagnosis in primary care, and the link hopefully should take you directly to that document. Next slide, please. And there's been a very recent publication in BMJ by the teams in Edinburgh and in Aberdeen, very respectable, very well-known pediatric teams. That talks exactly about the challenges in diagnosing asthma in children very elegantly. So I'd strongly recommend that you read that if you want more information. Next slide, please. But given that I know that you are very pressed for time, I have just put the snapshot of what the summary of that article is, which is essentially what we are saying, that asthma is a clinical diagnosis based on history and examination, and in many cases, a response to trial of inhaled corticosteroid is what is going to give you the diagnosis. The other thing is, again, we see many children where they've been told that they cannot have a diagnosis because they are under 5, and whilst that's not completely true that you cannot diagnose asthma in somebody who's under 5. I think often the perception is because you cannot do the objective testing easily in that group of children, often they are told that they cannot have a diagnosis. And again, Dr. Moss has gone over the under 5s in a previous webinar, and you'd have more detail on that if you wanted to access that webinar. But we know that we can make a diagnosis under 5. Slightly more difficult in the under 2s because, again, we know that cough, wheeze are very common symptoms that are present in respiratory tract infections. So slightly more difficult there, but certainly you can make a diagnosis in children under 5. And again, just to summarize, that the tests that can be done are there to help support or exclude a clinical diagnosis, but should not be used solely to make or exclude a diagnosis of asthma. Next slide, please. I think hopefully I've kept within time, and if you have any questions, we can take questions. Thank you for
Excellent. Thank you very much, Dr. Ramphel. That was really informative. So I can see lots of people have introduced themselves in the chat, which is great. Thank you very much for that. That's really helpful and helps us understand, where we're managing to reach. Does anybody have any particular questions they would like to raise for Dr. Ramphel or any other colleagues in the team? There hasn't been anything that's been brought forward in the chat so far. Just raise your hand or perhaps put a question in the chat.
There was a hand raised by Carol Curtis.
Oh, thank you. Thanks, Carol. Carol Curtis?
Yes, hello there. It was really just to ask, how useful would you find a full blood count in children under 16? And would you consider doing a full blood count in a child who's 4 or 5 to see what their eosinophils are doing? Is it useful or not? Sorry, did you get that?
Yeah.
Yeah.
So we wouldn't routinely do that, I have to say, because I think eosinophilia again is quite. We don't always see a raised eosinophil on the blood count in children, and I think I'll let Sam answer if she thinks differently. But it's not something that we would do routinely. I think that you would go more by the clinical diagnosis and giving a trial of inhaled corticosteroid.
So they're not. So eosinophils and IgE they're neither specific nor sensitive, and more so the younger the child. So it's not something that any of the guidelines advocate. Certainly not in early diagnosis. So no.
Okay, thanks very much.
Is that another hand that I can see?
Yeah, Carl Henderson.
Thank you. Yes, Carl.
Just wondering, if you make a diagnosis of a child 5-year-old around asthma, where does it fit in about when they say children go out of asthma, or how does that work if you diagnose them at 5, and then at what age and how do you know if they're grown out of it if you've given them a diagnosis and long-term inhalers?
I think it again would depend on the clinical progress, because even the ones who have asthma, some children will outgrow it. So it will depend very much on their progress. So again, it will also depend on what is triggering the symptoms. So if you've got multiple triggers, they're not just infection, then it would be reasonable to make a diagnosis of asthma. Again, I'll let Sam add to that.
So what I would say is, when you do your annual review for children who've got a diagnosis, you shouldn't be afraid to step up and step down. And if you eventually end up stepping down till they're on no treatment, then after a period of time, I would remove the diagnosis. Because we do, certainly I've got children who had very severe asthma and go through puberty and things become much milder. So I think it's important that we do diagnose for the reasons that Nilmani said. But on your annual reviews, if you step down to nothing, then we shouldn't be afraid to remove that diagnosis or, move it to a past diagnosis.
How long would you give before you removed it? Because I've just seen a child and they haven't used any inhalers in a year. They're doing sports and they're not getting breathless. So because they haven't used them, I requested them in 12 months, I've stepped them down to nothing, but just said to the parents to keep in the back of the mind, if the breathlessness does reoccur, to come back and see us.
Yeah, I think 12 months is a very appropriate time, because you need to think about what the triggers are. And most of the children and young people will have cold weather and viruses as a trigger, and some of them will obviously have hay fever and so on. So I think as long as you've had a period of time where they will have been exposed to all of their triggers and they haven't had exacerbations. And similarly, if you step them off inhaled corticosteroids completely, you leave them with salbutamol, and then if they pick up more salbutamol, then that needs to kind of trigger a review and a thought about, do they go back on inhaled steroids?
Yeah. Thank you.
Great. Thank you very much. That's really helpful. There's a question in the chat there from Danielle Bell. I wonder whether or not Dr. Ramphel might be able to respond to that. I'm just conscious of time, so I'm hopeful to move on. So if we could just have the next slide, please. Apologies, I can't see the slides moving, so I'm hopeful that it should now say thank you. And just to say, moving on, we're now going to hear from Carol, who's going to talk to us about inhaler choices for children. Carol is our lead community asthma advisor and is also a respiratory nurse at James Cook Hospital and has progressed lots of work for us as part of the asthma leadership programme. Over to you, Carol.
Thank you. Hopefully in this session, I'll be exploring some of the issues and challenges related to inhaler choice. Next slide, please. Appropriate selection and correct use of inhaler devices is a fundamental component in the management of asthma. It's well known there are many challenges with the use of inhalers, and no one device suits all patients. The correct use of inhalers and concordance with prescribed therapy are major influences in achieving better clinical control and improved quality of life. These examples shown on the slides here are representative of only some of the potential choices that face us in decision making, and therefore increase the opportunity to find an appropriate option for each individual patient. Inhaler devices vary in several ways. In the types of inhaler, they may be propellant or dry powders. They vary in the number of actuations or frequency required. An inhaler technique is also varies considerably. Ensuring the understanding of technique is essential to the best drug deposition and therefore asthma control. Next slide, please. It's also important that the correct technique is done with the spacer and that the right spacer is used with a prescribed type of inhaler. All families and children should have training in the correct use of inhalers, but also importantly, the maintenance and care of the spacer, including when to replace it. Links to videos are important to enable that patients can actually physically see how to use their inhaler correctly. And you can see here on this slide, there is a link to the Beta Asthma website, which has a representation of a vast number of inhalers and how to use them appropriately. It's interesting that the NRAD review of asthma deaths recommends that an assessment of inhaler technique to ensure effectiveness should be routinely undertaken and formally documented at annual review, and also checked by pharmacies and practitioners when a new device is dispensed. Next slide, please. When using a spacer, the spacer actually creates a space between the mouth and the medicine, and this space helps the medicine break into smaller droplets, and it allows the speed of the actuation to be slowed down. The smaller the droplets, the more easier they can move throughout the airway and improve deposition. There is some evidence to suggest previously that large volume spacers deposited more medication into the lungs, but with the advent of new smaller spacer designs and improvements, the deposition in some brands of smaller spacers has increased significantly. It's certainly a finding from my experience in clinic that some children remain on a spacer with mask far longer than they should. And in actual fact, removing the mask actually improves deposition. There's also a consideration of tolerability, portability, and convenience when choosing a spacer. I know personally from my adolescent age group, it's often the case the spacers become abandoned and they're using their meter-dosed inhaler as the technique of choice. We know that meter-dosed inhalers have poor technique and deposition in general. And if this presents in clinic, this is an ideal opportunity to discuss alternative inhaled devices. Next slide, please. A significant number of factors influence inhaler choice for children and young people. There's a wide age range within paediatric respiratory medicine, and they all have the challenges throughout the whole spectrum. Younger children are generally treated with inhalers and spacers, but may take some time to become tolerant, in contrast to the adolescent age group who have preference to the type of inhaler they are willing to use. Other pressures on young people are evident, and it isn't easy to admit that you've got asthma or prepared to use an inhaler in front of your friends. In this situation, it may be that a smaller, more discreet inhaler may be of choice. Children with persistent asthma can develop tolerance, poor perception of symptoms, and this may prompt the decision to use a MART type inhaler. MART inhalers have maintenance and reliever therapy within one inhaler, and this might ensure more inhaled corticosteroid is administered on symptomatic days. This is also a useful choice in children and young people who we know that have very poor concordance. Also, inhaler choices in children with learning difficulties or children with disabilities may differ in relation, and this may be linked to ease of use and ability to inhale correctly. Having an understanding of the influences on children and young people who have asthma promotes the best opportunities to come to an agreement on the best treatment plan. Education and understanding of the importance of asthma for children and young people and families and how their treatment works is a key influence on successful outcomes. Inhaler technique should be checked at every opportunity. The key message for particularly in our adolescent age group is that an inhaler is only as good as the one that will be prepared to be used by the child or young person. Next slide, please. In the previous section of the webinar, Dr. Ramphal discussed the process of diagnosis, and this is also influential on inhaler choice. A child or young person with sudden and frequent onset of symptoms may be offered different choices to one who has mild, infrequent symptoms. Some young people with difficult asthma clearly describe their preference as to which inhaler works best for them. If someone enjoys sport or exercise, it may be considered that a small portable inhaler is one of choice. However, ensuring that in the case of severe exacerbation, there is a spacer and meter-dose inhaler of rescue inhaler available nearby. Many schools now have generic relief inhaler and spacers in school. We have, as a network, been working significantly with schools within the NANC, and there's an awareness that asthma has significant impact on school attendance. Low attendance should prompt a review, not only of inhaler type of the treatment and the technique as part of the process. Results from diagnostic testing may also support choices of treatment and inhaler types. Next slide, please. Various and national guidelines offer extensive advice on groups of treatment. Here's an example of BTS guidelines. This is a stepwise adjustment to treatment with either increase or decrease in medication depending upon level of asthma control. Asthma control, as previously discussed, is based upon the outcomes of assessment, history, and physiological testing. Next slide, please. Within the NANC, there are some regional guidelines. Seen here is the North Tyneside, Gateshead and North Cumbria guidelines, offering more specific advice on different inhalers related to age and ability and recommendations on dosage and guidance. Next slide, please. This slide has the TEAS guidelines with similar content and advice, but also include guidance on greener choices. It is important to remember that it is a consideration and not mandatory, but should contribute towards inhaler choice. The good news is there will be joint regional guidelines published in 2024, which will aim to support choices of inhalers and treatment and create uniformity across the NANC ICS. Next slide, please. And finally, on our discussion of greener considerations, it is important to be familiar with the impact of each type of inhaler. The graph highlights the major differences between some of our most common types of inhaler. A simple change can have an impact. The change from Ventolin to salbutamol can have a significant reduction on carbon emissions. We have had some discussions recently on the effect of the changeover for some of our patients and have all agreed that some of our patients dislike some of the changes that we make and feel them as effective as Ventolin. If this is the case, then it would be advised to discuss other options with those patients. Good advice also when prescribing is to use brand names and therefore limit the risk of substitutes being used instead, which may have higher emissions. Also of importance is the safe disposal of used inhalers, and it is recommended that they are returned to pharmacies. Thank you. That was the last slide, so any opportunity for questions, please ask away.
Excellent, that's great. Thank you, Carol. A really good opportunity to be able to share that with the group tonight. So I will open the floor to questions, but there is something in the chat here from Danielle Bell. This is identifying if a child only has asthma symptoms when exercising, but is totally fine at other times. What's the best thing to do? Is it PRN, ICS or LABA? And a query about the licence for Symbicort.
So I think this is really interesting, and there's a lot of discussion in the paediatric respiratory world about this. I think the GINA initiative is probably the way of the future, and I think certainly nobody would criticise you for, and it's certainly safer to prescribe a combined inhaled steroid and LABA. I think where the child can't take Symbicort as a turbohaler, which most 6, 7 and 8 year olds are not able to, the chances of them using 2 separate inhalers is less. But I think what we need to be careful of is if you just prescribe a SABA, that you have relatively low threshold for introducing a regular inhaled steroid, and certainly, you know, look at the frequency of the SABA usage.
Okay, excellent. And I think the other couple of queries have been responded to in the chat. So is there anything anyone else wants to raise or query? Any hands? I can't see any hands at the moment. Catherine.
Oh, hi. I was just wanting to query about montelukast and the potential of nightmares in children. Would it be appropriate to prescribe it for morning use, or does it not make a difference? Or is this not appropriate? Is it better to have it at night?
So I have replied to it in the chat. I think we do occasionally do it, but my preference would be that you add in a LABA. You know, if they're having side effects from the montelukast,
right, okay.
I would add in a LABA and forget about it. I think if you're finding them really difficult to manage, you can consider that. And we do have the occasional child that uses it intermittently. But the reality is, although the science is really, really good with montelukast, it actually doesn't make that much difference in the majority of patients.
Okay, thank you very much.
So
Right.
the question in the chat, sorry, Louise, from Danielle. So it is okay at the moment to prescribe a SABA only if exercise symptoms, but if they're using it more than 3 times a week or going through more than 3 inhalers a year, then they should have an inhaled corticosteroid. And I think it is really difficult in children that they do exercise frequently. But actually, if you're needing to use salbutamol frequently for exercise-induced symptoms, you're better with a background inhaled steroid. Does that answer the question, Danielle?
Okay, great. Thank you very much. Okay, so I'm just conscious of time. So for the third section of our webinar, we're going to hear from Sam Moss relating to the overuse of SABA. Dr. Moss is our consultant respiratory paediatrician and our clinical lead for the work in the asthma leadership group. She has worked within respiratory for 15 years and obviously has a keen interest in this area and a passion for improving outcomes for children and young people. Over to you, Sam.
Thanks. Next slide, please, Claire. So I thought we'd take this opportunity because there's a lot of discussion about overprescribing and overuse of SABA, and I think it's very important that we try and tease the two out. And I think to start with, we have to talk about what a definition, what is SABA overuse? And as expected, there isn't really a consensus. So the current BTS and NICE guidelines say 3 or more days a week using SABA for relief of symptoms. Now, I think that's interesting, relating back to the previous question. If we tell people to take it prophylactically before exercise, does that count? And I think it's difficult. What we do know from the National Review of Asthma Deaths, which is now over a year old, is over half the patients had more than 6 SABA inhalers in the previous year, and nearly 40% had over 12. So it has to be a risk factor. Unfortunately, in NRAD, we don't have a denominator, so we don't know what the rest of the population is like. The National Bundle, which I'm sure you've all heard us talk about ad nauseum, says that we should report the number of patients with more than 3 SABAs a year, which I think in children is really aspirational, but it does give us a ballpark really for how much SABA is acceptable in terms of usage. Next slide, please, Claire. So the big problem I have when I see patients in my clinic is it overuse or overprescribing. And I've just written some questions down here, which I guess if people feel they can answer out loud, do. But if not, just have a little think yourself, you know, how many SABA inhalers does a child need at diagnosis? And I think this is really difficult, isn't it? Because it depends on the child's circumstances. We have lots of children now who mum and dad don't live together, they spend a night at grandma's and they're at school. So I don't think it's unreasonable when you make that diagnosis of asthma. Sorry, Katie, you've got your hand up. Were you going to answer?
Sorry, it was more of a question mainly around the child that needed diagnosis and the salbutamol requirements. I'm getting a lot of queries from schools asking for the child can't just have a salbutamol inhaler at home, they've got to have one at home and at school. So sorry.
And I think that's reasonable. I think when you first diagnose a child, for them to have them in multiple places is reasonable. So if they say to you, I want one at my house, I want one at dad's house, I want one at grandma's, I want one at school, that potentially is reasonable at diagnosis. But then I think the next question is how often these inhalers need to be replaced.
Yeah, that answers that, thank you.
So the inhalers only need to be replaced when they've run out. So what I counsel my patients is, that's fine at diagnosis. Then what I think you should do is have a full inhaler in your cupboard so that when one runs out somewhere, you've got one to hand. As soon as you get that full inhaler out of the cupboard, you ask for your next one. So people should not be asking for 4 inhalers at a time, because your inhaler at school, your inhaler at dad, your inhaler at grandma's and your inhaler at mum's should not all run out at the same time. If you are only using salbutamol twice a week, 3 times a week, one inhaler has 200 doses. If you've got 4 inhalers, that is 800 doses. They can't run out every month. So I think this is where it needs teasing out. I think the other question. Sorry, yes?
I was just going to inhalers in schools. I thought there was a government document issued where the schools could get one inhaler and an aero chamber, which should be kept for an emergency. Because if you look at the financial cost and burden of issuing all these inhalers, it takes a lot out of your prescribing budget.
So I think there's a difference between the schools having inhalers for emergencies, so that is if the child is having an asthma attack, than for the children who perhaps need salbutamol pre-exercise. And the reality is, I mean, certainly at schools, they either need to be replaced as they're finished or as they expire, which shouldn't be that big a burden of inhalers. So, and you know, at the end of the summer holiday, at the end of the summer term, those inhalers should be returned to the family so they can be used in the pile. So I don't think it should be that big a burden. And certainly I think as we move on to teenagers and how schools are and more independence, if the children can have their inhalers in their bag and on them themselves, that is much more preferable. So I do think it is reasonable for a child to have an inhaler at school, and the emergency inhalers is just about what happens when you have an acute attack. Does that answer that question?
But some schools take the inhalers off the children, so is it not that we need to get the children educated to always have a blue inhaler with them?
It is, but I think it depends on the age of your child, doesn't it? And the ability of your child to take on the self-management, because I'm not sure that I would trust a 5-year-old to have the inhaler, whereas a 13-year-old, I think they should be having the inhaler on themselves. Sorry, somebody else has got their hand up.
Yeah, sorry. I was a school nurse in a previous life before I moved into GP practice, and schools generally, like you say, the emergency inhaler is literally for that. It's if somebody has an asthma attack and they don't have their own inhaler with them, because once it's used, then they generally would give it to that child and say, can you replace that emergency inhaler now? In terms of the ages, generally, again, with younger children, the inhalers tend to stay in the classroom in primary school because they are generally in that classroom all of the time, and they would go off and they would take them to PE when they go. I think the issue comes when the children move up to senior school. I had a young lad the other day whose school, he was at Durham Johnson, huge school, and the school insisted on keeping his inhaler in a central area. So I did say to Mum, she needed to speak to school and say, actually, that's not appropriate anymore. He's moving all around the site. He's travelling to and from school independently. That's the time when he needs to carry his own.
Adele, I'm sorry, it's really interesting, your points, but in the interest in time, I think we do need to get on, and we can perhaps carry on with the discussion a bit more at the end. Yeah. So I think the other question is then what happens to unused inhalers? And what we don't want to be in is in a situation where there's lots of half-used inhalers left in PE bags and under beds and so on there. And I think it is really important that we encourage recycling, appropriate recycling of inhalers. So I think the point of this slide really was to think about, are we overprescribing? Are they having enough? If we're clear a child is overusing salbutamol or having more salbutamol than we think is appropriate, then that should trigger a review of their baseline treatment and an increase in their baseline treatment. So the need for SABAs should go down. Next slide, please, Claire. So this, if you can see it, is what I see when I'm in clinic and I go into the Great North Care record. And the sad thing is, I didn't even have to think about searching for a child. I just went into my next asthma clinic, picked one of the children at random, and this is what came up. So criticisms here, you can see one, they're being prescribed Ventolin, which is, Carol pointed out, is not the best environmentally friendly inhaler. The other thing is, if you can see, each time they're being given 400 doses, which is actually 2 inhalers. So this child was prescribed 2 inhalers twice on the 31st of January, the 2nd of January, the 22nd of November, and the 28th of September. This should not happen. I think after that initial diagnosis, only 1 salbutamol inhaler should be prescribed at a time, unless there's a specific conversation around, oh, unfortunately, 2 have run out, we've had a change of circumstances or whatever. And I think the frequency of these prescriptions, now I obviously don't know what's been dispensed, I can only see the prescriptions, but the frequency of them, again, should trigger something in the practice. Next slide, please. I think Carol did tap on the environmental impacts, and we looked just at some figures locally. So this is adults and children. There's over 200,000 salbutamol inhalers prescribed, and this is at a cost of nearly £500,000. Each inhaler has a carbon footprint of 28 kilos if this is an MDI, and that's the equivalent of driving from the northeast to London and back 2,500 times. So again, just putting it into the environmental impact. We also are suspicious that children get free prescriptions, and we know that there is a lot of inhaler sharing amongst families that go along, which has a whole host of issues. There's obviously the fraud issues, but there's also the issues about that family member having poorly controlled asthma and using medication that isn't prescribed for them. Next slide, please, Claire. So I think, how do we tackle it? I feel very strongly a child with asthma should never be left without access to a SABA. They shouldn't be reliant on SABA, but every child should be able to access it. So I would hate to get to a situation where children are told, you've had too many, you can't have it. What we need to do is trigger a discussion with the family and the patient. And as I said, if necessary, increase the background treatment. It's surprising how often when you speak to the families, oh, I just tick everything on my repeat prescription, or oh, I don't pick it up, I leave it with the pharmacy because we don't need it, or oh gosh, yeah, we've got about 10 in the cupboard, or he's got about 6 under his bed. So there's all these reasons. And I think we really shouldn't accept the SABA being routinely ticked on repeats. Every time there should be a question if they're really needed. And after initial diagnosis, as I've said several times, please only prescribe 1 SABA at a time. So next slide, please, Claire. So this is just, I think if we've got a few more minutes just left for discussion, and this is just a reminder that although we've talked about the environmental impacts of the MDI, SABA does come in all shapes and forms. And in terms of looking at control, we should look at the handheld devices as well as the MDIs. And if patients are collecting excess of these, then it still needs to be looked at in terms of control. Thank you.
Great, thanks, Sam. That's excellent. So if we could just take, if there's one more question, I'm conscious of time. We are a little bit behindhand, we're a few minutes behindhand, but if there is one more question that we can do. Right, Katie?
Sorry, it's just a quick question, just because you guys will be familiar with the use of the Easyhaler. Obviously, we're trying to get patients to move over to the Easyhaler. What I'm getting is quite a bit of feedback from my young people saying they don't really get on board with it, they don't like it, they don't want to use it as much. What's your experience, particularly Sam Norman, feedback from patients that you're seeing in clinic with the Easyhalers? Are you finding it's a positive feedback with it, or?
Most of our patients love it. They love the fact that it's handheld, that you can tuck it in your pocket or a sock. And I would guess the question would be about checking their technique. If they're not finding it as useful as their technique really is good. The other thing I would just add is we do always advocate in children that they, even if they go onto a dry powder SABA, they should have one MDI and spacer in case of severe attacks. So certainly the routine carry around with them should be their handheld device. But if they're, if they're at home ill, they need to have access to an MDI and spacer.
And a spacer, yeah, that's fine. Thank you.
Excellent, thank you. There are just a couple more questions in the chat, so I wonder if we could go through those, colleagues. But in the meantime, I think we need to move on in the interest of time. So we've got, for our fourth and final section, we've got Dr. Hegab, who is going to talk to us about paediatric asthma referral pathways, when to refer, and our North East North Cumbria resources. Dr. Hegab is consultant paediatrician at James Cook with an interest in respiratory medicine. And he is also a clinical advisor to our network, and is obviously engaged in this work, and also has a regional role for the North Eastern Yorkshire. If I could hand over to you, Dr. Hegab.
Thanks, Louise. Next slide, please. So in the interest of time, I'll try to be brief as much as I can. In the next few slides, we're going to discuss referrals to and from primary care. Initially, we're going to discuss when to refer to primary care. Definitely, that's going to be from the community, which include community pharmacy and schools and sports clubs. Criteria for community pharmacy referral to primary care include over need of SAPA. For all the previous discussion and for all the previous reasons, including the need for more than one SAPA for a child at the time of diagnosis or using in different houses or schools, if they need more than 6 over a year, that's an indication for referral to primary care for a review. Another indication is if they only collected less than 75% of prescribed inhaled corticosteroids over the last year. The general principle is overuse of SAPA means that the asthma is not controlled. Under prescription or under use of inhaled corticosteroids mean that the asthma is not well controlled. If you need to issue an emergency supply of SAPA to a child and young people, you need to think why. And this is another indication for referral to primary care. For community pharmacy and to facilitate this referral, as part of our referral pathway, we have developed an asthma referral letter template. This is
Sorry, Mohammed, your slides aren't moving forward. We're still on the title slide.
Can we move that one to referral to primary care, Claire, please?
Mine was on the correct one.
Mine is in the correct as well.
Mine's on the correct one.
Yeah.
So is mine.
Good.
Yeah,
okay.
They have moved on.
Yeah, I've got the right slide.
Good. So there is a template, which I will give the link as part of these slides. There is a template letter to be used by community pharmacy and schools, so they can tick the boxes, highlighting the name of the child and just tick the box about the reason of referral, and you can send that as a referral to the primary care team. Next slide, please. Criteria for referral to primary care from schools and other community organizations, including absences from school in relation to asthma, non-participation in physical activities because of asthma, frequent need of reliever inhaler more than twice weekly might indicate an indication of poor asthma control. And as again, there is a template for the school, other than the template letter for the pharmacy. all what they need to do, just add the name on the top, tick the box about the indication for referral, and then use the letter as a referral to primary care. Next slide, please. Before we talk about referral from primary care to secondary care, it is important to highlight how to manage uncontrolled asthma. Managing of asthma itself is out of the remit of these few slides, and there's different guidelines, GINA guideline, BTS guideline. But what I wanted to highlight that before referral from primary to secondary care, we need to ask ourselves, why is asthma not controlled? There's few questions, and again, there is a tick box checklist on a template letter that we can use for referral from primary to secondary care, which I will go through in the next few slides. First, why asthma is not controlled and how is it not controlled? We have to assess current asthma control using the asthma control test. Second, we have to ask, is there any modifiable risk factors like other comorbidities, like atopic conditions, hay fever, eczema, allergy? Is there any exposure to tobacco smoking or exposure to secondhand smoking? Maybe we can offer smoking cessation advice and signpost to smoking cessation services. Obesity is another risk factor that we have to think about. Third, we have to review inhaler technique. As Sam just mentioned, sometimes all what we need to do is to realize or help the child through inhaler technique that they are not getting their inhaler properly. So inhaler technique is a very important step before making any referrals to any other level of care. Review of concordance is another important factor. We have to ask about what medications are they taking, who is responsible for giving the medications, how frequent do they take the medication, and the type of question is sometimes very important. So I personally ask, how many times do you miss that particular medicine for a week? Because most of the teenagers, for example, they will say, yes, we're taking it. But unless you highlight the importance and what exactly are you taking and how frequent and what inhaler technique, sometimes it gives you the wrong information that things are fine while it is not. I have been recently involved with a couple of cases where severe asthma, and despite the fact that every single clinic I was highlighting the importance of inhaler technique and concordance, we discovered that some of the concordance was misunderstood, and that's why she was not taking the inhaler the right way. Next slide, please. Still under the same title of managing uncontrolled asthma before referral, we have to identify and eliminate other triggering factors like exposure to allergens, environmental factors, and environmental factors that include factors at home, factors at school, and factors at sports activity and other organizations where the children spend considerable amount of time. And then comes the optimization of care. And I know in secondary care, we are very oriented with the BTS guideline and we keep sharing it. And I, as part of the group who developed this guideline and this referral pathway, we had representation for primary care. And I know that primary care, they use the GINA guidelines more than what we use when we use it in secondary care. But the beauty of the Beat Asthma website is that under the resources section for primary care health professionals, there is both guidelines. So feel free to go through that guideline and step up or step down after you review the inhaler technique, eliminate the other factors. And if despite this, still the asthma is not controlled, this is when you have to consider referral to secondary care. And it's very important also to review other impacting factors like diet, weight, lifestyle, and signpost to further support. And as we mentioned before, smoking is a very important one. Please discuss with the parents and the carer about the housing and the housing condition. And we all know about AWAB's law consultation that's going on at the moment, which is closed on the 5th of March. And it's going to be mandatory for house lords to inspect and act on risk factors for houses. Next slide, please. Other risk factors to consider before making your referral. Is there any other medical or long-term condition that might be affecting or have an impact on asthma? Mental health and psychological factors. Social deprivation, family circumstances. Is it a looked after child and young person? Is there any support needed for the family? Nutrition, and definitely school environment as part of the environment that might trigger asthma for children and young people. Finally, once the decision has been made, yes, the next slide, that's right, Claire. So when to refer? After you address all this, if they still need more than two oral corticosteroid courses, despite addressing all these factors, this is an indication for referral to secondary care. Persistent chronic symptoms for more than 3 months, even after escalation of management according to the PTS or GINA guidelines. If they need hospital admission after escalation of care or ED attendance, that's another indication for referral to secondary care. Overuse of SABA more than 6 per year, including any other inhalers, as we previously discussed in Sam's and Carol's talk. If the asthma control test is persistently less than 20, despite trial of appropriate management and strategy based on the BTS and GINA guidelines. If there's diagnostic uncertainty, even after following the advice given by my colleague, Dr. Ramphel, at the beginning, persistent psychosocial concerns or safeguarding concerns. Sorry? All right. As I said, this referral pathway. Next slide, please. So this referral pathway is on the Healthier Together Northeast and North Cumbria. It has been developed by a group of colleagues, including myself, representatives from primary care, representatives from the community. It has a template for referral between pharmacy and primary care, schools and sports clubs and primary care, and referral template letter to refer from primary care to secondary care, including a checklist of all other modifiable factors that we have discussed. It's very easy to use, so I would definitely recommend having a look at it. And as part of this slide, we will send you the link for the Beat Asthma, which includes the link to GINA guideline and BTS guidelines. Thank you.
Thank you. Thanks very much, Dr. Hegab. I appreciate we're now technically out of time, but we have 5 or 10 minutes if people want to ask any further questions or raise any queries about that. Please feel free. Right, okay, so we've got a question here in the chat from Lisa, who is querying whether or not this is included on ARDENS. And I don't know whether or not this actually relates to the SABA question or the conversation that's happening. I think this might be talking about the guidelines and obviously whether or not this is on ARDENS.
There's not a specialist pediatric template on ARDENS.
Yeah, and there's it usually has like referral pathways and stuff on there. So I was just wondering if it's actually on the new referral letter is on there, or do we have to?
It is on Healthier Together. No, it is on Healthier Together. What is ARDENS? Is that?
It's just a like a clinical system that we use with System 1, where we have like respiratory. So we'll have all the asthma review stuff on there. So it would be handy if it was actually added on to that, so we can just populate it from the system.
The only problem there is people that use EMIS templates don't have the same access to the quality of data.
It is currently on the Healthier Together website, but we can explore if that's possible. I wasn't aware of ARDENS because we were going to use it, but we can ask that question to our primary care leads. But currently it's on Healthier Together website, Northeast and North Cumbria Healthier Together.
Yeah, okay, thank you.
That's a really helpful link there. That's something that we can certainly pursue, because if we can ensure that consistency, that would be something really helpful. Okay, we've got 2 hands, Carol Curtis and then Katie Coupland.
Hello, yes, sorry, this is a very quick question back to the Easyhaler. I just wondered at what age do you would think an Easyhaler could be offered to a child? Is there an age where you think they couldn't manage it? Thanks.
I think Carol's probably best to answer this, but realistically, it's not as young as they say.
Yeah, I think as the presentation inferred, I think it's on an individual basis. We've got some 8 and 9-year-olds who can't use a dry powder device yet and are still on spaces because we've assessed that they're not ready to change over. Whereas I've seen children as young as 4 or 5 may manage a dry powder device in certain circumstances. So I think it's the education advice, the demonstration of the technique, and if possible, if you have an at-hand placebo, to actually get the child to show you how they would use it. And the difference then, of course, is we're seeing this child taking their inhaler in a clinical setting without symptoms. And it's really important to know that in the chance of an acute exacerbation, that changeover of device will be sufficient in the case of an acute exacerbation, and that they would still have close to hand a dry powder device and a spacer in case it didn't work effectively.
The other thing I would just add is not all dry powder devices are equal. Certainly, I think the turbo haler is incredibly difficult to use, and we have some kind of early teens who can use, say, an easy haler but not a turbo haler.
Yeah, that's right. The flow rate is considerably higher. Inspiratory flow rate 60 litres with a turbo haler.
Thank you.
Okay, thank you very much. Great. Now, next, Katie.
Sorry, it was just me again. I might have missed this at the start. I was having some problems at the start. It was just a query about referrals and Montelukast. I'm quite new to primary care, and I've had a couple of instances where the GPs have sent patients to myself and asked about Montelukast and initiating Montelukast in primary care. Now, it's something that I would have traditionally shied away from, given the fact that if someone's initiating Montelukast, it does demonstrate that they're quite poorly controlled asthma. So I was just wondering what your thoughts are on initiating Montelukast in primary care, and I know some. Sorry, yeah.
I think absolutely Montelukast should be initiated in primary care. If we got referred every child who wasn't well controlled on an inhaled steroid, we'd be inundated and we just couldn't cope with them. So yeah, absolutely have a therapeutic trial with adequate counselling.
I agree with Sam. Both BTS and GINA guidelines highlight that the threshold for referral to secondary care should be after step 2, and Montelukast comes under step 2. So that should be initiated in primary care before thinking about referral to secondary care.
Right. Well, thank you very much for the clarification. That's brilliant. Thank you very much.
Thanks, Katie. Okay, we've got a hand here, Claire Adams.
Hi, thank you for an excellent evening. Yeah, just to say, to come in to Katie, to back you guys up, we use it very, very frequently in primary care, Katie, so please don't be shy to use it. And in fact, if you're looking at NICE guidelines, they say use it second line after an ICS, although BTS don't endorse that and say use obviously Labonex, but obviously in the younger children, it can be used as a monotherapy in the children under 5, can't it, guys, in asthma? So yeah, we use a lot of it in primary care.
Thank you very much. That's brilliant.
Nice to see you.
Thank you.
Thanks for that helpful feedback. So Carol Curtis, is that a legacy hand or is that a new question?
Beg your pardon, it's a legacy hand. Thank you.
No problem at all. Okay, is there anything else from anybody? Just looking at the chat, I don't think we have got any new questions, and I'm acutely aware that we're now 6 minutes over time. So if we could have the last slide, Claire, that would be really helpful. Are we on it? Hopefully this is a thank you slide. So just to round up, want to express a huge thank you to all of those individuals who've stayed with us tonight and for your interest in this work. And also a massive thank you to our presenters from the leadership group tonight, and obviously those colleagues who are helping answering questions in the chat, which is great. As I've mentioned, we will monitor this chat for a further 24 hours to try and pick up any questions that we haven't been able to discuss or resolve as part of this session. And obviously we will collate the questions and answers and share them with the delegates following the event. And the last slide here, which you can hopefully see, just provides some links to the Child Health and Wellbeing Network webpage, and also to the link to join up to our kind of ever increasing membership. So that's all from me, and just to say a huge thank you to all colleagues who've participated tonight. Thank you very much.
Thank you, everyone.
Bye.
Thank you very much. Bye. Thank you.
Thank you.